There are 8 marks per questions. So we think, I mean, the last pandemic exam had 25 questions, therefore 200 marks. So what we will do is, because you will have 5 minutes at the time of the exact of examination, what we'll try and do is give you 4 to 5 minutes. I trust you have a pen and paper, preferably separate sheets of pen and paper with you, because it's a good idea to answer on separate sheets to get into the examination groove, so that it's not surprising for you when you're doing the exam. As it is, an examination is a terribly stressful condition. The second option that I would like you to do, see, I mean, because India is coming through to OSCEs only very recently, one of the problems that we did realize is sometimes data is given on your first slide, and when you go to the next one, which actually has the questions, the data, you may not have the data given. So it is always a good idea to write down the data from the question that has been given. The most important thing is, please do not carry, I tell this to all my students every session, don't carry your baggage forwards. Don't let it influence your next OSCE sessions. If you really think about it, 8 of 200 marks is only 4%. So please remember. So without further ado, we'll start off, and we'll walk you through the nuances of the OSCE, all 3 of us today. And I'm going to be your starting batsman, as it were. So, guys, if you're ready, pen and paper ready, your first question up, and we'll give you about 4 minutes for this. Best way, sorry, I just muted. Yeah, the best way to go about answering this in 5 minutes, and 5 minutes isn't a long period of time. You'll probably realize that 4 minutes itself is not a long period of time. So become a point, write answers in points, principally in points. So without much ado, let's have a look and see what what you could write, how does the body react to a surgical insult? Point. Sympathetic nervous system overdrive, causing increased CO, increased glycolysis. Endocrine response to ACTH, increased glucocorticoid, insulin resistance. Acute phase response, cytokines, kinins, interleukins, TNF alpha, interferons, clotting cascade activated, elevated acute phase proteins, downregulation of albumin and transferrin production, vascular endothelial response, lower tone and coagulation, platelets and leukocyte binding. If you want to, take a screenshot of this, because if you're heading towards the exam just around the corner, take a screenshot, because I'm going to give you that entire cover it in the best thing we think is by points you can cover the entire topic, because as examiners you're given key points which have to be mentioned. So if you write a sentence, it's a waste of your time of 5 minutes. Right. So what is the metabolic response to trauma? Can you mute yourselves, please? Yeah, that's all right. So what is the metabolic response to trauma? Ebb phase may have reduced energy expenditure and reduced metabolic rate. This ebb and flow phase and anabolic phase goes back to the realms of surgical history. So you need to remember that. Okay. So ebb phase, reduced energy expenditure and reduced metabolic rate. Flow phase, a dramatic increase in metabolic state, catabolism, often many days with a negative nitrogen balance and impaired glucose tolerance. And if you want to give an example, the two examples that you need to give are burns and acute pancreatitis, two of the most dramatically catabolic phases that the human body can be exposed to. Anabolic phase, replacement of fat and glycogen reserves and proteins are synthesized. So that's your anabolic phase. Lipid metabolism, major source of energy after trauma. Lipolysis stimulated by sympathetic overdrive, ACTH, cortisol, glucagon, decreased insulin level and effect, so insulin resistance. Ketones released, used by all except the three structures that cannot use ketones. The only three structures in the body are the CNS, the RBC, and the WBC. Remember that. I mean, they're obligatory anaerobes. They have to use glucose. So ketones released, used by all except brain and blood. Free fatty acids and glycerol undergo gluconeogenesis in the liver. Carbohydrate metabolism, high glucagon and low insulin and corticosteroid induces anti-insulin effect. The glycogen stores mobilize to create a temporary hyperglycemia because, as I told you, glycolysis for energy for CNS, leukocytes and RBCs, which have an insulin-independent mechanism. They do not require insulin to take up glucose. All other cells in the body require insulin. Glycogen stores deplete in 24 hours, gluconeogenesis from lipid breakdown and amino acid protein breakdown. Protein metabolism, skeletal muscle release, amino acids, anti-insulin effect. Requirement peaks about 7 days, often prolonged, proportional to the grade of injury. Only source if exogenous protein not provided, and that is where you need to be careful. That's the catabolic phase. You have to provide proteins. Can cause endothelial dysfunction and intestinal mucosal atrophy. Guys, it's not very fair to other people if you're going to keep your connections on unmute. Please mute your connections, please. The requirement peaks about after 7 days, often prolonged, proportional to the grade of injury. Only source if exogenous protein is not provided. Can cause endothelial dysfunction and intestinal mucosal atrophy, loss of barrier to bacterial translocation, and usually a loss of above 40% is usually fatal. Okay, so we've covered the entire huge chapter on metabolic response to trauma and how lipid, protein, and carbohydrate is metabolized. So we require you to do it in point form. Do not go into writing a huge big sentence. Okay, right, chaps. Now the next one, don't start answering just yet. This is a practice. Don't start. You're given an OSCE session. A 44-year-old man was admitted on a 2-day with a 2-day history of acute gastroenteritis leading to severe diarrhea. His ABDs are given. So that is the scenario. You don't need to do anything right now because the question is sometimes given like that, which is fair enough. You see, the question is added, what is acid-base disorder? What is the anion gap? What is the compensation adequate? And the figures are given out here. Now, just to be difficult, guys, Dr. Patel, can you mute yourself, please? It is becoming unmute every time. Please mute your connections. Okay, because you have an exam coming up and we've just on limited time. So the question also could come like this. So which means you're basically left high and right because you haven't copied down these facts, okay, these data. So please, guys, make it a habit to practice writing down the data. So now the screen is all yours and you've got 4 minutes starting right now. So I'll give you 3 more minutes for this question. I hope you've copied down your data. Okay, guys, you will probably realize that not all questions are as huge as the first one. Will have a complete mix, but I hope you have your answers ready. So here is your data, and I hope in future you will always copy down this data. We will have examples like that, which comes in an essay type question, but you have to copy down the data. Right. So pH is 7.31, overall change is acid. Look at the PCO2, which is low. So it cannot be a respiratory acidosis. PCO2 high is respiratory, causes respiratory acidosis. But look at the bicarbonate. The bicarbonate is low, so it's contributing to the acidosis. So if you really assess and think about it, it's a metabolic acidosis. So we have here a situation of a metabolic acidosis, because the components are pulling in the opposite direction. So if it's pulling in the opposite direction, find out the anion gap. And what is the anion gap? The anion gap is sodium minus chloride plus bicarbonate. Some people and some authorities would actually take potassium with it. So if you're using potassium, your range is going to be some 4 units more. So it could be sodium plus potassium minus chloride and bicarbonate, or it could be sodium because potassium is usually low, and you subtract chloride and bicarbonate from it. Now, why do we do an anion gap? And the next few slides I'll try and explain to you. So, see, is the compensation adequate? For finding the compensation, there's a formula called the Winter's formula. So PCO2 should be 1.5 into bicarbonate plus 10. So it should be 34. So that's the Winter's formula. So think about it. Bicarbonate, how much is the PCO2? 33, very close. So the full answer would be a metabolic normal anion gap, that is normal, with adequate compensation. Now I'm going to go through a bit of fluid and acid and base. The reason is the normal pH is 7.35 to 7.45. And we know that there are two elements. You have a PCO2, if it's high, it is respiratory acidosis. If it's low, it causes respiratory alkalosis. So this is wonderful. It's a one-party rule. No ambiguity, no controversy. But the moment you come to metabolic, you have two major parties, and the two major parties are H plus ions and bicarbonate. So if you have a high H plus or a low bicarbonate, it's a metabolic acidosis. If you have a low hydrogen ion and a high bicarbonate, it's metabolic alkalosis. Have we finished? Not yet. We have independent members. It's just like a hodgepodge sort of metabolic problems are a bit of a hodgepodge, like a multi-party rule, because you have other acids which could either go up. If it go up, it contributes to metabolic acidosis, and if it goes down, it contributes to metabolic alkalosis. That is the reason that you need to know the anion gap. Okay, let me take it. So if we are going to interpret blood gases, that's the normal blood gas. And for those of you who are going to take exams outside, the PaO2 and PCO2 will be given in kilopascals. So it's 13 kilopascals of PaO2. CO2 is 5.3 kilopascals. Others staying same. In India, you would probably have the same thing in millimeter mercury, which is no great sweat. It's 90 to 100 for PaO2. PaCO2 is 35 to 45. So remember, that's the value in kilopascals. That's the value in millimeter mercury. Right. Now, throughout my life, I've used a chart, a very simple chart. I'm a simple surgeon, so I like all things simple. And the chart that I've used is this. So if you have a disturbance of acid-base balance, look at the PaCO2 first. If the PaCO2 corresponds to the changes, in other words, if the PaCO2 is high and the patient pH is also high, then it's almost certainly respiratory. Again, if the PaCO2 is low and the pH is also low, it's respiratory. So, I told you, for respiratory It's a single party rule, and it's no complications at all. But if the PaCO2 and the pH don't correspond, in other words, you have let's say a low PaCO2 and a high pH, or a high PaCO2 and a low pH, so it doesn't correspond. At that time, you look at this base deficit. So find out whether the base deficit corresponds to the pH. In other words, if you have a base deficit and the pH is low, it corresponds to the changes, which means it's metabolic. Find out whether the pH, if the pH is high and you have a base excess, then it's also metabolic alkalosis. So acidosis and alkalosis. Now comes the critical bit. Sometimes even SBE does not correspond. Then you have a mixed situation where it's far more difficult to assess. And let us go into that a bit. So you have compensatory mechanisms, and chaps, if you want to take a screenshot of this, please, because it has stood me very well in the travels of time. And, I started practicing, I've done my postgraduate in 1985, and it's helped me tremendously throughout my surgical life. So take a screenshot of this, please. If it's helped somebody who's a simple surgeon like me, I'm sure it will help you. And then you can expand on this. So look at the compensatory mechanisms. Physiologic, weak acids and its base salts, weak base and its acid salts. For example, bicarbonate, carbonic acid, intracellular protein like hemoglobin, phosphates in bone, pulmonary, changes in ventilation, acidosis, increased ventilation, carbon dioxide is blown off to compensate for acidosis. The moment carbon dioxide is blown off, you turn it into alkaline, so it's compensating for the acidosis. If you have alkalosis, you lower the ventilation, you try and retain carbon dioxide. The moment carbon dioxide is retained, it increases, tends to make it more acidic, so it's compensating for the alkalosis. Renal and bone acidosis, kidneys excrete excess H plus ions and retain bicarbonate. Alkalosis, the opposite happens, so the kidney starts excreting bicarbonate and retaining H plus. Also, the bone contains plenty of bicarbs and phosphates. So these are the compensatory mechanisms. Now, two issues which we talked about: compensation and assessment of other independent acids. The independent party members, independent parties that form a coalition government, sort of, they create all the problems. So compensation, what is the compensation? Standard base excess is the dose of acid or alkali to return the extracellular fluid to normal pH, that is 7.4, under standard conditions, that is at 37 degrees, at PaCO2 of 40 millimeter mercury. So base deficit is equal to metabolic acidosis. So it means you require that amount of base to return it to normal. Base excess is equal to metabolic alkalosis. So amount of acid required, you need to assess the amount of acid required to return it to 7.4. Now, there's one beautiful relationship between base excess and PaCO2. When the pH is normal, that is at 7.4, then PaCO2 and base excess are, SB standard base excess are equal and opposite. In such circumstance, a high PaCO2 is described as representing acidosis. We told you about that. A high SB must be the exact opposite, representing alkalosis. Fortunately, the slope for PaCO2, if you put in a base excess, when you put it on a chart at pH 7.4, gives a beautiful ratio. 5 units of change in PaCO2 is equivalent to 3 units of change in standard base excess. Therefore, a change in PaCO2, if I can give you the formula, there we are, change. Now that's the important thing. Change in PaCO2 over change in base excess is 5:3 at pH of 7.4. Unfortunately, sometimes only bicarbonate is given. Sorry, that should be 2. Sometimes bicarbonate is given. So when acidosis is present, The Winters formula says that if you, we are now not assessing the change. A base excess gives you the change, but if you're using bicarbonate, it means that you're actually assessing the actual levels of PCO2. So PCO2 is equal to 1.4 into bicarbonate plus 10. If you can remember this formula, but the one that is usually used is the acidosis formula. It's called the Winters formula. PCO2 is equal to 1.5 into bicarbonate plus 10. So guys, take a screenshot of this if you can, and then we'll go ahead for the next topic. So you see that is calculating the compensation that is required, okay? Now, assessment of other acids if present, the independent H+, the independent party members, that creates problems. So I'm going to give you 3 charts. So here I've used potassium, okay? An anion gap is equal to sodium plus potassium minus bicarb minus chloride is usually 12 to 16. Remember, I've put in potassium, otherwise it would have been 8 to 12. Okay, so there are 2 examples of low anion gap, which means it's less than 6 millicurie per liter, and usually in hyperalbuminemia and monoclonal protein. But that's not important because it's very rarely would you come across that. What you actually come across is the next, which is a normal acid-base anion gap. The normal anion gap 12 to 16, and there's a beautiful mnemonic. It's called ACCRUD, ACCRUED. Acid load, C for chronic renal failure, C, the other C for carbonic anhydrase inhibitors, R for renal tubular acidosis, U for ureteroenterostomy, E for expansion like extra alimentation, and D for diarrhea. I mean, this is just in case, just to give you a background of the acid base reality. You don't, if you're heading for your exam next week, take a screenshot, put it somewhere where you can use it later. But this is a normal anion gap problem. So normal anion gap with acidosis occurs in these conditions, and the mnemonic is ACCRUD. You have a high, and that mnemonic is mine. You call it U mild, high anion gap, which means you're adding potassium. Let's think about it. You have diabetic ketoacidosis. That is adding to your H+. Okay, so you'll have a very high anion gap, which is more than 16 millicuries per liter. And it's called U mild, U for uremia, sulfate, phosphate, and urate, M as in massive rhabdomyolysis, H+ and organic ions, I is ingestions, methanol or ethanol poisoning, and salicylates. L is for lactic acidosis, either L-lactate or D-lactate. D for diabetic ketoacidosis, where beta hydroxybutyrate and acetoacetate adds to this problem. So guys, I'm covering a huge topic in just a few slides. So bear with me, want to copy that just before the exam, but if you really want to, the one that should help you is, remember that chart, okay? If you haven't taken a screenshot, please take that chart. That will help you solving most of your acid-base problems. Just remember, when you have a mix, that is the time that you need the anion gap, and the anion gap indicates that there are some others adding to the H+ ions, H+, other than your normal sodium and sodium and potassium. You assess that is high, very high. There's there's some other value which is adding to it. So you have to remember that very high H+ means some other H+ ions are floating around, adding to your problem. So remember that. Right. Now, 4 minutes for this. This is another one of those huge topics which you need to answer in point form. 5 minutes is only a very short period of time, and I'm going to give you exactly 4 minutes for that. Okay, guys, I'm afraid I'll have to stop. I wish I could give you more time. So these were the basic questions. How do you classify hemorrhage? How do you resuscitate her? See, I mean, you need to know about the classification of hypervolemic shock, and you'll be surprised to see a tennis racket out there, and I'll tell you why. So the thing is, classification is depending on the loss in percentage, pulse rate, blood pressure, pulse pressure, respiratory rate, mental state, and urine output. Class 1 is less than 15% blood loss, blood volume loss, less than 100 pulse rate, normal blood pressure, pulse pressure is normal or high, respiratory rate is 14 to 20, mental state is slightly anxious. You would be if you've lost that bit of blood. Urine output is still more than 30 mL per hour. And just as a sort of a, we'll go into this in details, initial resuscitation of crystalloids, that's perfectly par for the course. Blood loss in percentage 15 to 30%, pulse rate of 100 to 120, blood pressure is still normal, pulse pressure is decreased, respiratory rate is 20 to 30, mental state mildly anxious, urine output 20 to 30 ml per hour. Class 3, you have a blood loss of 30 to 40%. Pulse rate goes up to 120 and 140, blood pressure is decreased, so is pulse pressure, respiratory rate is even higher, 30 to 40. You have beginnings of confusion coming in, and in urine output of 15 to 5 to 15 ml per hour. Again, chaps, please mute yourself. Class 4 hemorrhage, loss of more than 40%. Pulse rate is you're really in serious trouble out here. Pulse rate is more than 140. Blood pressure is extremely, you have this thready pulse sort of a thing, thready pulse. Blood pressure is almost unrecordable. Pulse pressure is hopelessly decreased. Respiratory rate more than 35, and you have a confused, lethargic individual lying, and urine output is minimal. So the resuscitation up from class 3 is with blood and blood only. Why did we have the tennis racket out there? The reason is there's a beautiful mnemonic which came from England, 15 to 30 to 40. If it's more than 40, the game is over. So that is where you're in very, very, very deeply critical, you have a deeply critical patient out there. Right, now resuscitation, you can actually write more than 5 books on this. And 4 minutes is actually not a fair time. But if you're given this sort of a scenario, again, go into points. Identify and treat the cause, recognize and treat reversible life-threatening injuries. Address, and you give some examples like putting in pressure dressing, things like that. Address ongoing blood loss. Stop the blood loss by putting in a pressure dressing. Electrolytes and acid-base disturbances have to be corrected. Volume deficit. If the mean arterial pressure is less than 65, you can give IV fluids till blood is available. But your choice in a hemorrhage is blood. Choice of replacement fluid, you can give crystalloids if you don't have blood. While you don't have blood, crystalloids, balanced solution preferred to normal saline. Colloids, no difference in the use of, if you do a randomized controlled trial, there's not a lot of difference in mortality between crystalloids and colloids. But if you're using, in the colloids, if you're using starches, there's often an increased need for renal replacement therapy. And sometimes you need to use blood and blood products. Right. Now, this, I purposely put this slide in black. This is not part of your answer, but it's just to tell you about what I said about crystalloids. Exogenous chloride administration has been shown to induce renal artery vasoconstrictions, acute kidney injury, hyperchloremic metabolic acidosis, GI dysfunction, and secretion of inflammatory cytokines, compared with using something like a balanced solution like a Ringer's. A commonly cited concern about the use of balanced salt solution is a risk for hyperkalemia. However, and this is from the nephrology discipline, comparative evidence has largely invalidated this, suspicion and indicate that the metabolic acidosis, which ensues after, here you have a seriously ill patient and you're transfusing huge volumes, large volume, 0.9% in sodium chloride administration may instead trigger extracellular potassium shift and consequence hyperkalemia. The next slide is also referenced, chaps, and this is just to tell you, used between colloids and crystalloids. The Cochrane analysis studied a huge number of patients of colloids. 28 studied starch, 20 studied dextrans, 7 gelatins. You don't need to put this in the answer again. 22 albumin of fresh frozen plasma. Each type of colloid was compared to a crystalloid, and this was a conclusion. Colloids versus crystalloids probably make little or no difference for mortality. Starch is probably slightly increased the need for blood transfusion, renal replacement therapy. It's not a very strong evidence. Albumin and FFP may make little or no difference to the need for renal replacement therapy. So these two slides are just to explain that statement, that little, so in that particular little snippet, you've finished that whole bit that I've given you as a reference. So that is how to complete a huge answer. Right, returning to resuscitation. Massive blood transfusion is defined as, traditionally we said more than 10 units for 24 hours, but lately with more aggressive treatment, actually there is more than 3 units per hour or more than 4 blood components in 30 minutes. ASA, American Society of Anesthesiology, suggests transfusions less than, if you have a patient whose hemoglobin less than 6 grams, you have to transfuse. Alterations in hemostasis, particularly if you have access to thromboelastography or other modalities due to acidosis and hypothermia, coagulation proteins getting diluted, platelets count getting diluted. So all these add to a problem with hemostasis. So suggested combination by observational studies, blood is to FFP should be 1.4:1, and this was the army units in Iraq. Blood, if you're using apheresis platelets, that's almost an equivalent of 8. So 1:8. Blood platelet versus FFP. This is one of the commonest use across multiple centers, is 1:1:1. This is purely an observational study across multiple centers, because we were told use 1 FFP for every 4 units of blood. I think it's gradually changing. Monitor IV crystalloids. It should not cross more than 1.5/1 to blood, because if you use too much of crystalloids in a situation of torrential blood loss, mortality actually increases. And there is also a scope of controlled hypertension to control further bleeding. So just answer in point format. So how do you monitor? These are the ways of monitoring. Through the phases: a rescue phase, the optimization phase, the stabilization phase, and the de-escalation phase. These are the ones that work throughout: blood pressure, heart rate, lactate, ABG, and pulse volume. Okay? Mental status helps in the rescue session, but isn't all that good for optimization, stabilization, de-escalation. Fluid balance and urine output comes into play from the last 3 sections: optimization, stabilization, and de-escalation phase. Also, an echo Doppler, initially you see the venous filtering, is mainly used in optimization phase. So is the wedged oxygen, superior vena cava wedged oxygen, also in optimization phase. Cardiac output assessment in optimization phase. So also in fluid responsiveness and fluid challenge. Of the resuscitation, we need to also mention about citrate infusion, complications of citrate infusion, metabolic alkalosis, low ionized calcium levels. If you're using 10% calcium gluconate, 10 to 20 ml should be given intravenously into a separate vein for each 500 ml of blood transfused. Avoid in liver dysfunction. We were told, we grew up with the idea that you had to give 1 every 4 units of blood, but this is the latest suggestion. from most high volume centers. If 10% calcium chloride is used, you only need to use 2 to 5 ml for every 500 ml of blood. Right? Okay, chaps. Prevention of hypothermia. You need to use blood warmers. This is the final slide. Hypokalemia, use of blood collected less than 10 days prior to transfusion. So fresh blood, washing of blood cells to remove extracellular potassium. So it is sometimes very unfortunate. You have huge answers. So please do not run away with it. Try and get as much of points across in the 5 minutes that is allotted to you. I mean, come on. I mean, the examiners realize that you can't write a whole thesis on in 5 minutes. Okay, chaps? So we're going to go to the next one. And the next one is as follows. And that's going to, you're going to have 4 minutes for this one as well. Okay, guys, I trust your answers are ready. So you're going to think of an anastomotic link. We're going to think of an incipient SIR surge. And we have here a metabolic acidosis with type 1 respiratory failure. Why do I call it type 1 respiratory failure? See, I mean, if with a metabolic acidosis, you've got a base excess of -4. So it's hopelessly metabolically acidotic and likely to be lactic acidosis with a very high anion gap acidosis. So the PCO2 should have gone down as it is to compensate for that. But the moment you have a PaO2 of 60 millimeter mercury, which means this patient is in hypoxia, so that is the primary cause that is driving the PCO2, driving excessive breathing. And as a result of which, in addition to having a metabolic acidosis, which requires the carbon dioxide to be washed out, both of them, both that PaO2 of 60 millimeter mercury and the base excess of -4, they're both driving this PaCO2 down even further. So because the patient is able to wash out the carbon dioxide, it's a type 1 respiratory failure as opposed to a type 2 respiratory failure, which is a restrictive type of respiratory failure where PaO2 of 60 would have been associated with a very high PaCO2 because the patient cannot wash that out. So the important thing to say, you're going to suspect anastomotic leak, incipient surge, and we'll ask you why it is surge. I'm just going to go into the next slide. You're thinking of metabolic acidosis with a superadded type 1 respiratory failure, and the management is usually resuscitation, including respiratory support. You need to say, give the heading of workup, put in the mild sort of thing. You've got the blood results with you, you've got the ABG with you, you've got to get the sodium potassium, you've got to get the urine assessed, and you've got to do some imaging study. What are the imaging studies? Once the patient is stable, the best way to go about it is to take the patient for a CT scan, urgent CT scan, provided the urea and creatinine permits. And there you find that there's free gas in the abdomen, which isn't immediately available as gas under the diaphragm. Because don't forget, you've just done an operation. You would have gas, a small amount of gas under the diaphragm, which could mislead you. And you need to go in for laparotomy. Now, before we do that, why surge is defined by the satisfaction of any two of the criteria below. A body temperature either over 38 or 36 degrees Celsius, a heart rate greater than 90 beats per minute, respiratory rate greater than 20 beats per minute, or partial pressure of carbon dioxide less than 32 millimeter mercury, a leukocyte count greater than 12,000 or less than 4,000, or over. This is often asked in an exam, why do you think this is surge? And this is your answer. It has to satisfy any two of these four criteria: temperature, heart rate, respiratory rate, and white cell count or type. Okay, right. So we go back to that slide. As we said, anastomotic leak, incipient surge, metabolic acidosis, type 1 respiratory failure, and the management. We've talked about resuscitation already in the previous thing. We've done the workup. Laparotomy, again, remember, guys, you've got 5 minutes, and 5 minutes isn't a huge bit of time. Details in bullet form. You could go in for re-exploration after resuscitation. After that, you do a thorough peritoneal toileting. Having done the peritoneal toileting, you take down the leaking anastomosis, you refreshen the edges, bring the top end out as an stoma, and after refreshing the bottom end, you drop it down as a Hartmann's procedure. So that's all you need to, that's all you'd be able to answer. And it is a good thing if you'd also mention a few of the causes and incidents. Remember, she's an elderly lady, and the commonest cause of failure of an anastomosis is lack of good blood supply at the edges, tension, and also that if she's elderly, hypoproteinemia, if she's diabetic or diabetes, and perhaps even the post-op phase, she had hypotension. So these are all the facts that you need to think and talk about. Now, Dr. Sinha has given me 5 to 10 minutes more, so I'm going to throw in another question for you, which is interesting. Okay. Remember what I told you about copying down all the data that is present. Please do that because sometimes they aren't repeated. So I'm going to give you 2 minutes for this one, and then we'll throw the questions open. I've designed these questions so that you actually get into the habit of copying down the data. So in your fresh answers sheet, please write down on one side the data. So here comes the questions. So now you will have 4 minutes, 3 minutes to give me your answer. I hope you have your answers ready. So the answers to that would be calculating the fluid replacement that you have to replace maintenance and replacement fluids. Guys, please. Yep, I've turned it off. Okay. Fluid maintenance or replacement. And the usual formulas we use is either the 150-20 rule. That's the rule for calculating maintenance fluids for over 24 hours. It's 100 ml per kilogram for the first 10 kilograms, 50 ml per kilogram for the next 10 kilograms, and 20 ml per kilogram for the every kilogram over 20. I'm fond of this, but you also have the 4-to-1 rule, remember? 4 ml per kilogram per hour for the first 10, approximately amounts to 96, 2 ml per kilogram per hour for the second 10 kilograms, so that's 48. So it approximately is the same thing actually. 1 ml per kilogram per hour for the last kilograms, last bit of kilograms. That works out to be 24 ml per kilogram. So actually, I find this easier. I'm poor at maths, so I find zeros easy to calculate. So there we are. Now, replace of losses means preoperative or nasogastric aspirate, vomiting or diarrhea, stoma, drains, fistula, etc. Most surgical ongoing losses are rich in sodium and should be replaced with 0.9% saline. So, that is one of the indications for 0.9% saline. Feces approximately use, this is the insensible loss that is calculated by the 10, 50, and 20 rule. Feces approximately 100 ml per day, lungs approximately 400 ml per day, and skin approximately 600, which increases to something like a liter if you are, if you are in a dry atmosphere. As also, the lungs can increase to a liter if you have or even longer if you have a patient on a ventilator. The daily requirements of electrolytes are sodium 1 to 2 milliequivalents per kilogram per day, potassium 0.5 to 1, calcium of 800 to 1200, magnesium 3 to 400, and I've got a little trick. So I call it the 1-2-3 rule. Potassium is 1 milliequivalent per day, chloride 1, sodium 1 to 2 milliequivalent per day, calcium 2 grams per day, and magnesium 300 milliequivalents per day. So that is a rule that was taught to me when I was very young, and I remember that. Of 1500. So you are going to plan to give him 3860, 2360 plus 1500 is 3860, but you have to deduct the amount that you're giving in IV medications. So total minus 600, that's what you're giving in augmentin and painkillers. So if you take that down, 3260. Now into that equation, so we're going to give him approximately 3 liters per day, but we need to give him a sodium of 63 to 126, a potassium of 63, and a chloride of 63. So now we know that we need to give him 3 liters, and we need to give him about 60 to 120 of sodium, approximately 60 of potassium, about 60 of chloride. And that is something we need to give him, provided his urine output is normal. And we know that urine output is normal. So now, how do you calculate? So you put in, this is the sort of chart that you would actually use. Remember that if you go back to, any one of you, since you've answered this question, anyone want to take a chance and give him 3 liters? How do you give him 3 liters? 6 units of 500 ml. So that gives you 3 liters. So what would you give him? Remember that you need to give him a sodium of 60 to 120, a potassium of approximately 60, and a chloride of about 60. Any takers? Remember that. So of the 6 bottles that we are giving him, if we give him, remember that we need to give him potassium of 60. So if we give him an isolite M, 2 isolite M's, that should give him around 70, which is perhaps all right. Okay, unless you want to add KCl, which contains 20 milliliters of potassium in each ampule. Okay, so that's the other way of doing it. You can add potassium to his solution. We need to give him 120 of sodium. So remember that each bottle of Ringer lactate would contain 65. That's 130 per liter. Okay, remember it's 130 per liter. So if we give him 2 units, 2 bottles of Ringer lactate, we actually give him 130. So that roughly takes care of his sodium requirement. We would either need to give him an isolite M, which then pushes up the sodium. So we can't use isolite M. So what we can do is use 5% dextrose or use potassium in Ringer lactate. So you need to give him, let's say, 2 5Ds. We give him 2 Ringer lactates. Now, what else would you use? Think about it. We've already given him 130 of sodium. Okay? So we can't give him any more of sodium. Come on, guys, give it a try. That's your chart that you need to fill in.
So 5% extras to.
Okay, yeah, sure. Because you can't give him any more sodium, isn't it? We've crossed the limit. Okay. So see, I mean, when you drop next time you're in the ward and you're drawing up a fluid schedule, please remember, if you work on this for about 2 or 3 weeks, you'll find that it becomes very second nature to you. Okay, right. So you will be asked, this is part of the scenario that you often get, and this is a scenario you often get at, if you're going in for your MRCS, you would almost certainly get a scenario like this. It could be an OSCE session and you actually sit down in front of your examiner and work that out for 10 minutes. So that's a bit of a relief. It's not 5 minutes. Okay, guys. Right. I hope you've got that. I want you to take a screenshot of that, definitely, and preferably a screenshot of that as well. So that, and remember that. If you're heading for your exam, you don't have time to go through a ton of books, so just remember that. And remember that if you, in an exam, work out a chart like this and work out the amount of fluid requirements that you need. Right, guys, and I am stretched into timing for Dr. Sinha, so I'm sure he's going to come in. Remember that we need to give him magnesium. So 10% calcium chloride contains 100 milligram per ml of calcium, and magnesium sulfate solution 50% contains actually almost 500 milligram per ml. So remember that magnesium is something you can't use, which is why there's a fair bit of reserve in the body. Okay, so calcium and magnesium need to be supplemented. If this patient, as he's had a radical gastrectomy, he might be without food for quite some time, so you need to assess that factor that into your replacement as well. Right, guys. So just some tips. You will have to answer on separate sheets, which are collected after each OSCE. That's what has happened in the DND. Write down, please remember to write down whatever data is given. Sometimes the second and third slides may not have it. Please do not carry your baggage forwards. Don't let it influence the next OSCE sessions. Remember, 8 marks of 200 marks is, whether you like it or not, 4%. It's not a huge amount of marks. Don't spoil the next 96%. So have a plan, answer in point forms. You have only 5 minutes. It's not a essay type question. They don't want an essay type question. Just answer in points, get your marks and get out, because we all want you to all get through. So do not let 4% spoil the 96%. So guys, last, want to have a bit of a break before Dr. Sinha comes. Just grab a coffee, grab a